Welcome to the Deep Dive.
It's good to be here.
Today, we're cracking open a stack of material that takes us on a journey through the world of some seriously common medications. You know, the ones used to treat issues with our breathing, our eyes, our ears, and our skin.
Yeah, it's quite a range.
Think of this as your shortcut, maybe, to understanding what's really going on with that bottle or tube from the pharmacy aisle.
That's a good way to put it. We've pulled insights covering everything from the sniffles and sneezes you get with a basic cold or allergies, all the way down to the more complex airway issues like asthma and COPD. Then we zero in on treatments for eye and ear problems, things like infections, pressure issues like glaucoma, even the drops doctors use just to look inside your eye.
Right.
And finally, we'll peel back the layers on managing everyday skin conditions like acne, psoriasis, and even how we approach burns.
So our mission for this deep dive is to really dig into this material. We're going to try and extract the absolute most important nuggets of knowledge for you, focusing on how these medications work, what they're really for, the potential side effects you absolutely need to know about, and crucially, the safety tips that make all the difference in using them effectively.
Exactly. Let's really unpack this material together.
Okay, let's kick things off at the top, literally, with the upper respiratory system.
Yeah.
This material spends a good chunk of time on medications for those common complaints like the common cold and allergic rhinitis, which is just, fancy talk for hay fever.
Right.
The first big group it dives into, antihistamines.
Right. And the core mechanism here is pretty straightforward, actually. Antihistamines work primarily by blocking something called histamine at specific spots in your body called H1 receptors. Now, histamine is a chemical your body releases, often in response to allergens like pollen or dust, or even just irritation.
Okay.
And when it's released, it can cause those familiar allergy symptoms like increased nasal secretions, the runny nose, and it can also cause smooth muscles to constrict.
Like the tiny muscles in your nasal passages. That makes sense. Explains this stuffy feeling.
Precisely.
Yeah.
So blocking those H1 receptors directly counters those effects, helping to dry things up and reduce congestion caused by that histamine response.
Okay. And the material talks about two main generations of antihistamines. What's the headline difference between them?
The absolute major difference that jumps out from this source is drowsiness. First-generation antihistamines are notorious for making you feel sleepy.
Oh, okay.
The classic example, diphenhydramine, which you probably know as Benadryl, is specifically called out for causing significant drowsiness. The material even notes its half-life is typically 2 to 8 hours.
So the effect, including that sleepiness, can stick around for quite a while then.
It can, yeah. And the material says they also tend to have more of what are called anticholinergic symptoms.
Anticholinergic symptoms, so remind me.
Exactly. Anticholinergic effects happen because these drugs can block acetylcholine, another neurotransmitter, at certain receptors. The material lists effects like dry mouth, urinary retention, and blurred vision. And you asked why these are safety concerns. Well, it's because these aren't just minor annoyances. Especially the drowsiness, dry mouth, and dizziness, which the source highlights as most common with Benadryl.
Okay, so drowsiness and dizziness could increase the risk of falls, maybe particularly for older adults, or make it unsafe to drive, that sort of thing.
Definitely.
Dry mouth sounds uncomfortable, but maybe over time could lead to other issues, like dental problems.
Potentially, yes. Chronic dry mouth can affect dental health. And if it's severe, it could contribute to dehydration if you're not actively increasing your fluid intake. The source makes a point of mentioning the need to assess patients for urinary retention and blurred vision specifically because these can be more serious side effects of these anticholinergic effects.
Right. It tells you these aren't trivial.
No, not at all.
And it sounds like first-gen antihistamines aren't just a simple cold pill you can give anyone. There are contraindications listed.
There are, and they're important ones. The source lists using them with caution or avoiding them altogether in cases of acute asthma attacks, liver disease, COPD.
Chronic obstructive pulmonary disease.
Right. Also acute narrow-angle glaucoma. And if you're already taking certain antidepressants, specifically MAOIs.
Monoamine oxidase inhibitors.
Correct. This tells us these older medications can have broader systemic impacts and interact dangerously with other conditions or drugs. It really underlines why giving your doctor your full medical history is so important.
Got it. So first gen equals potential drowsiness, those other anticholinergic effects, plus specific conditions where you should definitely avoid them. What about the second generation ones? We see suffixes like bridine or cerizine in their names, things like that.
Yes, second-generation antihistamines like cetirizine, Zyrtec, fexofenadine, Allegra, loratadine, Claritin, and even azelastine, Astelin in its nasal spray form. Well, they were specifically developed to address the downsides of the first generation.
Yeah.
The main goal was to make them much less sedating and significantly reduce those anticholinergic side effects.
So less dry mouth, less drowsiness, less risk of blurred vision or urinary issues. That definitely sounds more user-friendly for most people's daily lives.
Exactly.
And the material notes, they are indeed used more often now because of this improved side effect profile.
Precisely. They also tend to have a longer duration of action, which is a major plus for convenience.
Right, less dosing.
The source mentions fexofenadine having a half-life of 7 to 15 hours and loratadine around 22 hours. So this allows many of them to be taken just once daily, which is ideal for managing chronic, ongoing allergy symptoms without needing to constantly redose or deal with that daytime sleepiness.
Okay, that makes sense. Moving on from antihistamines, the material talks about decongestants. And we see a distinction between nasal and systemic forms. What's the mechanism behind how these work to clear congestion?
Well, decongestants work by causing vasoconstriction in the blood vessels lining the nasal passages.
Okay, constricting the blood vessels.
Yeah. When your nose is stuffy, those blood vessels are swollen and dilated, making the passages narrow. By causing those vessels to constrict or shrink, decongestants effectively open up the nasal airways, making it easier to breathe through your nose.
And the difference between applying them nasally, like a spray, versus taking them systemically, like a pill,
Yeah.
what's the trade-off there?
Nasal decongestants, like oxymetazoline, which you probably know as Afrin,
Mm-hmm.
they're applied directly into the nose as drops or a spray. They work very quickly because they're right there at the site of congestion, and they generally have fewer systemic side effects because less of the medication is absorbed into the rest of your body compared to an oral pill.
Okay, that sounds good, but...
And here's where it gets really interesting and is a crucial caution from the source.
Hmm.
They are much, much more likely to lead to something called rebound congestion if you use them for too long.
Yes.
The material strongly emphasizes only using nasal sprays like oxymetazoline for a maximum of 3 days.
Rebound congestion. That's where your nose actually gets more stuffy. Maybe even worse than before if you stop using the spray after using it too long.
Exactly.
It creates this kind of vicious cycle where you feel like you need it. A classic example of how a quick fix can become a problem if not used exactly as directed.
It is. It's a well-documented issue. Systemic decongestants, on the other hand, like pseudoephedrine, Sudafed, and phenylephrine, neosynephrine, are taken orally.
Right, the pills.
They take a bit longer to start working because they have to be absorbed into your bloodstream and circulate, but their effect lasts longer because the medication is distributed throughout your body. But because they affect blood vessels throughout the body, not just in the nose, they come with more potential systemic side effects.
The material describes some of these side effects as fight or flight responses. What does that actually feel like for someone taking an oral decongestant?
It can feel like your body is sort of ramping up, a bit like a stress response. You might feel jittery, restless, or nervous. And because they cause widespread vasoconstriction, they can also lead to an increase in blood pressure. The source also notes they can potentially raise glucose levels, which is something important to be aware of, especially for certain individuals.
So definite cautions for people with conditions like hypertension or diabetes then.
Absolutely. The material specifically highlights using pseudoephedrine with caution in patients with diabetes and hypertension. They also carry a warning for those taking MAOIs, similar to the first-gen antihistamines, because that combination could significantly and dangerously increase blood pressure.
Wow.
The source also notes that systemic decongestants can cause rebound congestion, although it's generally less common than with the nasal sprays.
Okay, good to know. So we've covered antihistamines to block the reaction and dry things up, and decongestants to shrink those swollen passages. But allergies also involve a lot of inflammation, right?
They do.
What about tackling that directly? The material mentions intranasal glucocorticoids.
Right, these are steroid nasal sprays. And their primary use, as outlined in the source, is specifically for allergic rhinitis, managing the inflammation caused by allergens in the nasal passages.
Okay.
Examples include fluticasone, Flonase, triamcinolone, Nasacort, beclomethasone, and butanide, Pulmicort. As steroids, their core action is anti-inflammatory. By reducing that inflammation, they help decrease swelling, congestion, itching, and sneezing associated with allergies.
Anti-inflammatory makes perfect sense for treating allergy symptoms. Can you use these steroid sprays at the same time as antihistamines, or is it usually one or the other?
No, you can combine them. The material says they can be used alone or in combination with H1 antihistamines. For many people with moderate to severe allergic rhinitis, a combination approach can actually offer more comprehensive symptom control.
Okay. And side effects. Is there anything major to worry about? The material mentions a potential serious issue with continuous use.
Well, local side effects like nasal dryness, some irritation, or maybe occasional minor nosebleeds can occur with continuous use. Systemic effects are generally rare when they're used properly at recommended doses because the medication is mostly staying local in the nasal tissues.
Right.
However, the source brings up a potential serious complication that can result from incorrect administration. A perforated nasal septum.
Oh, wow.
Yeah, the material gives a very specific instruction. Point the medication away from the septum, that's the wall dividing your nostrils when you spray. Repeatedly aiming the spray directly at the septum can irritate and potentially damage that delicate tissue over time. These sprays are typically used seasonally or for courses maybe less than 30 days at a time.
That's a critical but probably easily overlooked detail for safe administration that can prevent a pretty significant complication.
Absolutely, it's all in the technique.
Well,
Now let's move on to medications that deal specifically with cough. The material divides these into two main types, antitussives and expectorants.
okay, antitussives. Sounds like they work against coughs.
They do. Their primary use, according to the source, is to suppress non-productive irritating coughs. You know, those coughs that are dry, hacking, don't really bring anything up, but are just bothersome and maybe make it hard to sleep or talk.
Mm-hmm.
They work by acting on the cough center located in the medulla, a part of your brainstem, effectively suppressing the reflex that makes you cough.
The material lists both opioid and non-opioid types. Can you give us some examples and maybe how they differ?
Sure. Dextromethorphan is a very common non-opioid example found in many over-the-counter cough medicines. The source notes that, unlike some opioid cough suppressants, it generally does not cause significant respiratory suppression or sedation at typical doses. It has an 11-hour half-life when taken orally, so it offers relatively long-lasting cough relief.
And are there conditions where you shouldn't use dextromethorphan?
Yes, it's contraindicated in patients with COPD or those who have chronic coughs, like the kind you might see with smoking or chronic bronchitis, and also with MAOIs because it can increase the effects of the MAOI drug. And the point about COPD is really important and insightful. If you suppress the cough reflex in someone with COPD, you're essentially taking away their body's main way of clearing mucus and secretions from their airways.
Ah, right.
Coughing is actually necessary for them to keep their airways open and breathe effectively, so suppressing that cough can actually be harmful in those specific cases.
That really clarifies the why behind that contraindication. It makes sense. The material also mentions codeine as an opioid antitussive, often found in prescription cough syrups combined with other meds.
Yeah.
But it explicitly states it's no longer approved for pediatrics and can be addictive. That's a significant safety warning, especially regarding kids.
It's a very important point, yeah. And it reflects the current understanding of the risks of opioid use in younger populations. Now, switching over to expectorants, they seem to approach cough from a totally different angle.
Yes, the material says their primary use is also for unproductive coughs, but instead of suppressing the cough, their action is to loosen bronchial secretions. The goal is to make the mucus thinner and easier to cough up, so the cough becomes more effective when it does happen.
Yeah.
They help you clear things out rather than just stopping the reflex.
Exactly. Guaifenesin, widely known by the brand name Mucinex, is listed as the most common example. It's believed to work by increasing the volume and reducing the stickiness, the viscosity of respiratory tract secretions. Side effects are generally pretty mild, can include some nausea and vomiting sometimes.
And the material highlights the best natural expectorant, which is
Water. Simple as that.
Yeah.
Staying well hydrated is a surprisingly effective way to help thin mucus and make it easier to expel.
simple but effective advice. Okay, that gives us a solid overview of the medications used for the upper respiratory system, tackling everything from allergy symptoms and congestion to different types of coughs. All right, now let's move down into the lower respiratory tract. This is where we encounter more serious conditions like chronic obstructive pulmonary diseases, or COPD, which includes things like chronic bronchitis, emphysema, and bronchiectasis, as well as bronchial asthma.
Yeah, these conditions share a common feature. They involve obstruction or increased resistance to airflow, particularly when you're exhaling. The source makes a really critical distinction here. COPD typically involves irreversible damage to the lung tissue and airways.
Irreversible.
Think of the damage to the air sacs in emphysema or the permanent inflammation and mucus buildup in chronic bronchitis. Asthma, on the other hand, while it is a chronic condition, involves inflammation and bronchoconstriction that are often reversible with appropriate treatment and management.
That reversibility is a key difference in how they're managed, I imagine.
Absolutely.
The material also briefly mentions restrictive pulmonary diseases, like pulmonary edema or fibrosis. It describes them as causing decreased total lung capacity and making the lungs feel stiff.
Yes, restrictive diseases affect the volume of air the lungs can hold or the ability of the lung tissue itself to expand, which is a different mechanical problem than airway obstruction. But our source material really focuses most heavily on the medications used to treat lower respiratory disorders, particularly those related to bronchospasm.
Right, the tightening.
The tightening of airway muscles and the inflammation seen in conditions like asthma and COPD exacerbations.
Okay. The first medication mentioned is epinephrine. The material notes it's a non-selective alpha-1, beta-1, and beta-2 agonist. That sounds like it impacts a lot of systems, not just the lungs.
It absolutely does, and that non-selectivity is why it's both so powerful and why it has significant side effects. Because it stimulates beta-2 receptors, it causes rapid dilation of the bronchioles, opening up the airways quickly.
Oh.
The source specifically highlights its use in anaphylaxis, that severe, life-threatening allergic reaction. In that kind of emergency situation, epinephrine is vital not only for opening the airways, but also because its action on alpha-1 receptors causes widespread vasoconstriction, which increases dangerously low blood pressure.
Right, crucial.
And its action on beta-1 receptors increases heart rate and contractility. These effects together are literally life-saving in anaphylactic shock.
But hitting all those targets comes at a cost in terms of side effects, right? The material lists things like tremors, hypertension, palpitations, even cardiac dysrhythmias.
Yes, precisely because it's non-selective, it strongly affects the heart via beta-1 and blood vessels throughout the body via alpha-1, in addition to the lungs. These widespread actions lead to those significant systemic side effects. And this is why its use is generally limited to acute severe emergencies like anaphylaxis, where its rapid, broad action outweighs those risks.
Okay, so very potent for emergencies, but not for everyday use. What about bronchodilators that are more specifically targeted to the lungs for, say, everyday asthma or less severe respiratory issues? The material talks about beta-2 adrenergic agonists.
Right. These are medications designed to be more selective. They primarily target the beta-2 receptors found in the smooth muscle of the airways in the lungs.
Just the lungs, mostly.
Mostly. By stimulating these receptors, they cause that crucial bronchodilation, relaxing the muscles and opening the airways. This makes them the mainstay for quick relief of bronchospasm in both COPD and asthma. They are most commonly delivered directly to the lungs via inhalers or nebulizers.
And common examples are things like albuterol, Preventil, Ventolin, levobuterol, Openex, and metoprolol, Alupit. The material calls them quick-acting.
Yes, they are often referred to as rescue inhalers because they are intended for immediate relief of sudden symptoms like wheezing, shortness of breath, or tightness in the chest during an asthma flare-up or maybe a COPD exacerbation.
Got it.
The source does note that even though they are primarily beta-2 selective, especially at the recommended doses if you overuse them, albuterol can start to stimulate beta-1 receptors in the heart a bit, leading to side effects like nervousness and an increased heart rate.
Okay, so more side effects listed for these. Nervousness, tremors, headache, tachycardia. And another caution for patients with diabetes, similar to what we saw with decongestants, is that right?
Yes, that's right. The source mentions that beta-2 agonists can cause an increase in blood glucose levels. So healthcare providers need to use caution when prescribing these to patients with diabetes, and blood glucose monitoring might be necessary for them.
The material provides really crucial step-by-step instructions on how to use an inhaler correctly. Why is getting the technique right so vital? It seems pretty simple.
You know, it might seem simple, but this might be the most important piece of practical information in this whole section. Proper inhaler technique is absolutely fundamental. It determines whether the medication actually gets deep into your lungs, where it needs to work, or if it just ends up deposited in your mouth or throat, where it won't do much good for your breathing.
Okay.
The steps listed are key. First, shake the canister well to make sure the medication is properly mixed. Then, breathe out fully to empty your lungs as much as possible. As you start to inhale slowly and deeply through your mouth, press down on the canister to release the medication.
Okay. Inhale while pressing.
Yes. After inhaling fully, hold your breath for about 5 to 10 seconds. This allows the tiny particles of medication time to settle down into your airways. Finally, exhale slowly.
And using a spacer device is recommended. What's that?
Yes, the material states that using a spacer, which is basically a chamber that attaches to the inhaler, can significantly improve medication delivery to the lungs. It holds the puff of medication for a moment,
Ah, right.
making the timing of your breath less critical, especially for kids or people who have trouble coordinating the press and breathe action. It also reduces the amount of medication that just hits the back of your throat.
Okay. And there's also a note about rinsing your mouth after using an inhaler. Why is that necessary?
This is especially important if the inhaler contains a corticosteroid, which many combination inhalers do, and we'll get to those in a minute.
Right.
Rinsing your mouth with water and spitting it out after using the inhaler helps wash away any medication residue left in your mouth or throat. This prevents local side effects, particularly oral candidiasis, which is a fungal infection commonly known as thrush.
Thrush? Okay. White patches.
Exactly.
The material also gives a specific order if someone is prescribed both a bronchodilator inhaler, like albuterol, and a steroid inhaler.
Yes, and this sequencing is critical for maximizing the effectiveness of both medications. The bronchodilator, the albuterol, should always be used first. Its job is to open up the airways.
Okay, open things up first.
You wait about 5 minutes after using the bronchodilator, allowing the airways to open, and then you use the steroid inhaler. This allows the steroid medication to penetrate deeper into the now open airways, where it can exert its anti-inflammatory effects more effectively.
That detail about waiting and the specific order is really practical and important for patients to know.
Absolutely, it makes a real difference. Next up, we have anticholinergics. The material lists tiotropium, Spiriva, and ipratropium bromide, Atrovent.
Okay, and the material notes that, unlike those quick-acting beta-2 agonists, these are not effective for relieving acute bronchospasms if used alone. But they are used in combination with other bronchodilators and are intended for long-term, day-to-day management, not really for use during an acute attack.
That's a key distinction. Anticholinergics work by blocking acetylcholine, which is a neurotransmitter that can cause bronchoconstriction. So by blocking it, they promote bronchodilation.
Okay.
While they do cause bronchodilation, their onset is slower than albuterol. Ipratropium starts working in maybe 5-15 minutes and lasts 2 to 5 hours. Tiotropium is once daily, so it has a much longer duration. They are primarily used as maintenance therapy for bronchospasm, particularly in COPD. They work synergistically with the beta-2 agonists, and when inhaled, they have minimal systemic side effects, which is a plus.
The material mentions a combination inhaler called Combivent, which contains both Atrovent, ipratropium, and albuterol, specifically used for chronic bronchitis. That makes perfect sense, combining a quick-acting beta agonist with a longer-acting anticholinergic for both immediate help and some longer effect in one device.
It does. It leverages that synergy. The material also notes nursing considerations for anticholinergics. Use cautiously with narrow-angle glaucoma, similar to some eye drops we'll discuss later, because anticholinergics can affect pupil size and potentially worsen the specific type of glaucoma.
Oh, okay.
And it reinforces the specific timing relative to other inhalers. 5 minutes after a beta-2 inhaler and 5 minutes before a steroid inhaler, just reinforcing the importance of that correct sequence when using multiple inhaled medication.
Okay, got it. Then we have xanthines, with theophylline as the main example discussed.
Right. Theophylline is an older medication with a range of effects. It stimulates the central nervous system, increases respiration, relaxes the bronchial smooth muscle leading to bronchodilation, and also affects coronary and pulmonary blood vessels. It even has a mild diuretic effect. However, the most critical point highlighted in the source about theophylline is its narrow therapeutic range.
Narrow therapeutic range means there's a very small difference between a dose that's effective and a dose that's potentially toxic, right?
Exactly. It's a very fine line. The material gives a therapeutic range of 5 to 15 micrograms per milliliter. Because this window is so small, monitoring blood levels of theophylline is absolutely essential to ensure the dose is within the effective range, but not climbing into the toxic range.
Why is it less commonly used now compared to in the past? It sounds like it does a lot.
It does, but the source notes it used to be a first-line treatment for asthma. However, due to that narrow therapeutic window and the potential for severe side effects, it's now primarily used as maintenance therapy for stable asthma or COPD. often when other safer options aren't quite sufficient.
And the side effects.
The severe side effects listed are concerning: restlessness, syncope, which is fainting, palpitations, tachycardia, a rapid heart rate, hyperventilation, nausea and vomiting, and significantly cardiac dysrhythmias or irregular heartbeats.
Wow, and there's a long list of potential drug interactions, too, which must make it even more challenging to manage safely.
Yes, that's another major factor in its reduced use. The source lists specific drugs like beta blockers, cimetidine, propranolol, and erythromycin that can increase theophylline's effects by slowing down its metabolism and increasing its half-life.
Meaning it stays in the body longer.
Right, increasing the risk of toxicity. It also increases the risk of digoxin toxicity and can cause dangerous cardiac dysrhythmias if used with beta-adrenergic agonists like albuterol. These interactions just underscore the need for very careful monitoring and medication review. Contraindications include seizure disorders and cardiac, renal, or liver disease, as these conditions can affect how the body processes and clears the drug. The source also wisely warns against consuming caffeine, as it has similar stimulant effects and can worsen theophyllines side effects.
Okay, lots and lots to keep track of with theophylline. Next, the material discusses leukotriene modifiers. Examples include montelukast, singulaire, zevalukast, accolade, and xylitol, xyphlos-CR.
Right. So leukotrienes are powerful chemical messengers in the body that play a significant role in the inflammatory process in asthma. They cause airway inflammation, increased mucus production, swelling, and bronchoconstriction.
Oh, yeah.
Leukotriene modifiers interfere with this process. Some, like xylitol, inhibit the synthesis of leukotrienes so they don't get made as much. Others, like montelukast and zafirlukast, block the receptors where leukotrienes bind, essentially preventing them from having their inflammatory effect.
So they help reduce the underlying inflammatory changes in asthma and prevent symptoms triggered by things like exercise or allergens.
Like a person
Measure. Exactly. Their primary use is for prophylaxis and maintenance therapy for chronic asthma, including preventing exercise-induced bronchoconstriction. It's crucial to note, as the material does, that they are not indicated or effective for use during an acute asthma attack.
Right.
Their onset of action just isn't fast enough for quick relief in that situation. Another clear distinction between rescue and maintenance medication. They're taken orally, and the material suggests taking them in the evening for optimal asthma control. Why is that?
Possibly because asthma symptoms often tend to worsen at night or in the early morning for many people. Taking it in the evening might provide better control during that vulnerable period. Side effects are generally milder than some other classes we've talked about, but can include fever, headache, dizziness, nasal congestion, and importantly, potential elevation of liver enzymes, which makes liver disease a contraindication.
Okay, then we have glucocorticoids, or steroids, delivered to the lower respiratory system. We saw them used in nasal sprays earlier, but here we're talking about managing airway inflammation deep in the lungs.
Yes, and their primary use, according to the source, is their powerful anti-inflammatory action in asthmatics. This directly addresses the hypersensitivity and inflammation that characterizes chronic asthma. The material lists inhaled, oral, and IV routes of administration. Inhaled steroids, like beclomethasone, Vanseril, delivered via metered dose inhalers, MDI, or dry powder inhalers, DPI, often in combination products like Advair, are considered the cornerstone of maintenance therapy for persistent asthma.
The go-to for long-term control.
Exactly. They are used daily to prevent asthma attacks by reducing chronic airway inflammation. Because the medication is delivered directly to the lungs, they have significantly fewer systemic side effects compared to taking steroids orally or intravenously.
And this is where that instruction about rinsing your mouth after using the inhaler is particularly important, right? Not just recommended, but really necessary.
Absolutely. Inhaled steroids can suppress the local immune system in the mouth and throat, increasing the risk of developing oral fungal infections like Candida albicans or thrush. So rinsing your mouth with water and spitting it out after each use is an essential step to prevent this. The source also notes that it can take up to 4 weeks of consistent daily use before inhaled steroids reach their full effectiveness in controlling asthma symptoms. This reinforces that they are for prevention, not quick relief of an acute attack.
The material mentions combination inhaled products like Advair, which combines a glucocorticoid, fluticasone, with a long-acting beta agonist. That sounds like a way to get both anti-inflammatory and longer-acting bronchodilation effects in one inhaler, maybe for people who need more control.
Yes, it's a common strategy for managing more severe or difficult-to-control asthma. It simplifies the regimen, too. Now, oral steroids, like prednisone, are typically used for short bursts. Usually a few days to maybe a couple of weeks, to treat acute asthma attacks or severe exacerbations when inhaled medications aren't quite cutting it. Because they are absorbed systemically, they have more potential for side effects than inhaled steroids. The source notes they might cause stomach irritation, so taking them with food is recommended. If used for less than 2 weeks, side effects are generally transient and reversible once the course is finished.
And 5E steroids like solumedrol. That sounds like for serious situations.
Yes, those are reserved for the most severe, life-threatening asthma attacks requiring emergency treatment and hospitalization.
Hmm.
And there's a critical caution highlighted in the material. If a patient is on oral or IV steroids for a prolonged period, generally more than 2 weeks, the medication must be tapered off gradually according to a specific schedule provided by a healthcare professional.
Tapered off, meaning slowly reducing the dose over time.
Exactly. Abruptly stopping steroids after long-term use can lead to adrenal suppression, where the body's own adrenal glands stop producing enough natural steroids because they've gotten used to the external supply. This is a potentially serious condition.
That gradual tapering is a really important safety point whenever steroids are used systemically for more than just a short burst.
Definitely. Okay, almost through the lower respiratory section, the material mentions mucolytics and cromolyn.
Eucalyptics. The name kind of gives it away to describe simply as medications that break up mucus. An example given is Mucomist, acetylcysteine, often administered via nebulizer.
Yes, their primary purpose is to liquefy and loosen thick, tenacious mucus secretions, making it easier for the patient to cough them up and clear their airways. This is particularly helpful in conditions like COPD exacerbations or cystic fibrosis, where mucus can be very thick and difficult to move.
Okay.
The source gives specific administration instructions for nebulized Mucomist. Do not mix it with other nebulized medications in the same nebulizer cup, and administer it 5 minutes after any bronchodilators have been given.
Ah, the timing again. Open the airways first.
Right, allow the mucolytic to reach deeper into the lungs to work on the mucus. Side effects can include nausea, vomiting, stomatitis, which is oral ulcers or inflammation, and rhinitis, nasal inflammation.
Interestingly, the material also lists Mucomist as an antidote for acetaminophen, Tylenol, overdose, recommending it be given within 12 to 24 hours. It even mentions it can be mixed with juice or soft drinks to make it more palatable because it apparently smells like rotten eggs. That's a completely different and potentially life-saving use for this medication.
It's a surprising and very important dual use, yes. It works completely differently in overdose. It helps replenish a substance in the liver called glutathione that gets depleted by the acetaminophen. For cystic fibrosis specifically, the source mentions Dornase alpha, pulmozyme, as another type of mucolytic that works differently by breaking down DNA strands in the thick mucus of CF patients.
What about cromolyn? What's its role?
Cromolyn is used for prophylactic treatment of bronchial asthma. So, like the leukotriene modifiers, it is not effective for treating acute asthma attacks.
Another preventative one.
Exactly. It works by stabilizing mast cells and eosinophils, which are types of immune cells involved in allergic reactions. It prevents them from releasing histamine and other inflammatory mediators when exposed to triggers. By preventing the release of these substances, it helps prevent the inflammatory cascade that leads to asthma symptoms. It's typically taken daily via inhalation for maintenance. Side effects are generally pretty mild and local, maybe some postnasal drip, irritation of the nose and throat, and cough.
Finally, the material has a reminder about antibiotics in the context of respiratory issues.
And the key message here is crucial and worth repeating. Antibiotics do not cure viral illnesses like the common cold or the flu. They're only effective against bacterial infections.
Right.
In the context of respiratory problems, they are used when a bacterial infection is present, such as a secondary bacterial infection that sets in when mucus is retained, or bacterial bronchitis or bacterial pneumonia.
So you wouldn't get an antibiotic prescription for your average cold unless the doctor suspects a secondary bacterial complication has developed. Examples listed include Bactrim or Septra, trimethoprim sulfonethoxazole, ampicillin and augmentin, a combination of amoxicillin and clavulanate.
Correct. Important distinction.
Okay, let's shift our focus now and take a deep dive into medications used for the eyes and ears. The material starts with some pretty interesting diagnostic tools for the eye itself.
Yes, diagnostic stains. These are a simple but clever way to help doctors examine the surface of the eye. These are basically colored dyes applied topically with eye drops. They help healthcare providers locate tiny foreign objects or lesions on the eye surface, evaluate dry eye by looking at how the tear film distributes the dye, or see other changes on the exterior of the eye.
The material mentions fluorescein sodium as a very common example. It's often used when someone might have squashed their eye, suspected corneal abrasion. The source says that under a special blue light, called a Wood's light or a slit lamp with a blue filter, any scratches or defects on the cornea absorb the dye and show up as a bright fluorescent yellow-green. That's a really helpful visual tool.
It really is. It makes even very small abrasions or defects clearly visible to the examiner. The material also notes that these stains can temporarily cause a harmless discoloration of the eye's exterior, making it look a little yellow, and can even temporarily discolor nasal secretions if the dye drains through the tear ducts into the nose. But this wears off within a few hours usually.
And there's a crucial instruction for patients who wear contact lenses if these stains are used. You can't just leave them in.
Absolutely vital. You must remove contact lenses before the stain is put in the eye. Contact lenses are porous and can absorb the dye, potentially leading to permanent discoloration of the lenses themselves.
Ah, okay. Good tip.
The eye can be rinsed with saline afterwards to wash away residual dye, and contact lenses can typically be safely reinserted after about 1 hour once the dye is gone.
The material also discusses topical eye anesthetics, basically numbing eye drops. Examples are proparacaine and tetracaine.
Yes, these drops are used to numb the surface of the eye. They work by blocking pain signals at the local nerve endings right there on the cornea and conjunctiva. They're commonly used during eye exams for procedures like checking eye pressure, tonometry, or just to make it possible to comfortably examine an eye that's painful due to an injury or a foreign body.
And the material highlights a significant safety concern when these drops are used, something about blinking.
Yes, the most important safety point is that the patient's blink reflex is temporarily lost or significantly reduced while the anesthetic is active. Your blink reflex is your natural protection for your eye against dust, foreign objects, or injury. With it gone, the eye is vulnerable.
Right.
This means you have to be extremely careful not to rub, touch, or wipe the eye until the numbing effect has completely worn off, which usually takes around 20 minutes or so. Contact lenses should also not be reinserted until the anesthetic has worn off and normal sensation returns.
That makes perfect sense. If you can't protect your eye by blinking, you need to consciously protect it from bumps or dust.
Exactly. Moving on to anti-infectives for the eye, one of the most common conditions mentioned is conjunctivitis, commonly known as pink eye.
Right. The material explains that it's inflammation of the conjunctiva, that membrane lining the eyelid and covering the white part of the eye, and can be caused by bacteria, viruses, or allergies. And crucially, it states that only bacterial conjunctivitis requires antibiotic treatment.
Exactly. This is a key point for proper treatment and antibiotic stewardship. Antibiotics are only effective if the infection is caused by bacteria. Viral conjunctivitis, which is very common, usually just needs time and supportive care, like cool compresses and artificial tears. Allergic conjunctivitis is treated with allergy medications. Using antibiotics for viral or allergic pink eye is ineffective and just contributes to the problem of antibiotic resistance.
Right. Okay. The material also lists ophthalmic anti-inflammatories, including corticosteroids, NSAIDs, immunosuppressants, and allergy medications in drop form.
Right. Corticosteroid eye drops, like dexamethasone and prednisone eye drops, are potent anti-inflammatory medications. They're used for various inflammatory eye conditions, such as severe allergic conjunctivitis, inflammation after eye surgery, or specific types of corneal inflammation like uveitis.
But the material points out significant risks associated with ophthalmic corticosteroids, especially if used for a long time.
Yes, there are several important caveats here. They can mask signs of infection and potentially delay the healing process, so they are contraindicated, meaning shouldn't be used, if there's an untreated ocular infection present.
Okay.
And here's another point that's really interesting and connects back to our earlier discussion. Prolonged use of corticosteroid eye drops can significantly worsen pre-existing glaucoma, particularly open-angle glaucoma, by increasing the intraocular pressure, IOP.
The pressure inside the eye.
Exactly. That increased pressure can damage the optic nerve over time and lead to vision loss. The source notes that these effects on IOP are usually reversible if the steroid drops are stopped, but the potential for damage while they are being used is a serious concern, requiring careful pressure monitoring.
So trying to treat inflammation with steroids could actually make a condition like glaucoma much worse by increasing the pressure. That requires very careful management.
It certainly does. It highlights the complexity. The material also mentions ophthalmic NSAIDs like diclofenac sodium and ketorolac eye drops. These are also anti-inflammatory and often used to manage inflammation before and after eye surgery, like cataract surgery.
Hmm.
A key difference noted is that NSAID eye drops do not affect IOP, unlike corticosteroids, which is a major advantage. However, they can potentially delay corneal healing or increase the risk of bleeding slightly.
Antihistamine eye drops are listed for allergic conjunctivitis, with potential local side effects like burning, stinging, and maybe some temporary blurred vision. And an immunosuppressant, cyclosporin ophthalmic emulsion, known as Restasis, is listed specifically for chronic dry eye. How does that work?
It's thought to work by reducing the underlying inflammation on the eye's surface that contributes to chronic dry eye disease in many people. It helps the eye produce more of its own tears over time.
Okay. Shifting focus slightly within the eye section, ophthalmic decongestants are discussed. These are the redness relief drops.
That's right. These drops work by stimulating alpha-adrenergic receptors on the small blood vessels in the conjunctiva, the white part of your eye. This causes vasoconstriction, narrowing those vessels and reducing redness and congestion. Examples are phenylephrine, nafazoline, and tetrahydrozoline.
They help get the red out, basically. But like systemic decongestants, there's a specific contraindication listed here too. Angle closure glaucoma. Why is that?
Because these drops can cause vasoconstriction and potentially affect pupil size, they could theoretically exacerbate this specific type of glaucoma by further obstructing the drainage angle in the eye, potentially triggering an acute attack in someone predisposed.
Okay, lubricants are mentioned simply for moistening the eyes and relieving discomfort associated with dryness. Things like artificial tears, generally very safe and widely available over the counter.
Yes, very common. Now, let's spend some time on glaucoma medications. Glaucoma is a major cause of irreversible blindness, usually associated with elevated pressure inside the eye that damages the optic nerve over time. The material differentiates between open-angle and angle closure glaucoma, the two main types, based on how the fluid drainage system in the eye is impaired.
It lists several classes of medications for open-angle glaucoma, which it says is the more common type, where the drainage angle is open, but the drainage channels themselves aren't working well. These include prostaglandin analogs, beta-adrenergic blockers, and carbonic anhydrase inhibitors.
Right. Prostaglandin analogs like latanoprost, Zalton, are often a first-line treatment. They primarily work by increasing the outflow of fluid from the eye, particularly through a secondary pathway called the uveoscleral pathway, which lowers IOP effectively.
Right?
The side effects can be quite distinct and sometimes cosmetic. A potential permanent change in iris color.
Permanent.
Yes, making blue or green eyes turn more brown over time. Also, darkening of the eyelids and the skin around the eye, and eyelash hypertrichosis, which means longer, thicker, darker eyelashes. More typical local side effects include stinging, itching, blurred vision, and redness.
Wow, a permanent change in eye color is certainly a significant side effect to counsel patients about before starting treatment.
It really is. Beta-adrenergic blockers like Timol are another very common class used to lower IOP. They work differently by decreasing the production of aqueous humor, the fluid made inside the eye.
Okay, less fluid being made.
Exactly. Side effects can be local, like eye discomfort or miosis, pupil constriction, but there's a potential for systemic side effects if the drops get absorbed into the bloodstream, especially in susceptible individuals.
Like we saw with the respiratory beta agonists.
Similar receptors involve. Systemic effects can include bronchoconstriction, which means they should be used with caution or avoided in patients with asthma or COPD. They can also cause bradycardia, slow heart rate, AV heart block, and potentially worsen heart failure because beta receptors are present in the heart and lungs. Applying pressure over the lacrimal duct, the tear duct near the nose, for a minute after installing drops can help minimize that systemic absorption.
Good tip.
Yeah.
And carbonic anhydrase inhibitors like dorzolamide in topical form or acetazolamide in oral form also work by decreasing the production of aqueous humor.
Correct. For angle closure glaucoma, which is often a sudden medical emergency caused by a physical blockage of the drainage angle leading to rapidly rising pressure, the material lists a similar range of medication classes, often used in combination to quickly reduce the very high pressure. Topical beta blockers, topical alpha agonists like brimonidine, which decrease production and increase outflow, carbonic anhydrase inhibitors, both oral and topical, prostaglandin analogs, less for the acute attack itself, more for long-term management after the pressure is controlled, miotics, and hyperosmotic agents.
Miotics, like pilocarpine, are listed as being used after the initial very high IOP has been lowered. How do they work?
Their action is to cause significant meiosis, or pupil constriction. This pulling action on the iris helps physically open up the blocked drainage angle, allowing fluid to drain out. The material makes an interesting point that they aren't very effective when the IOP is extremely high initially, likely because the iris tissue is swollen or ischemic and doesn't respond well.
Okay. And hyperosmotic agents like IV mannitol or oral glycerin, these sound serious.
They are. These are powerful agents used to rapidly lower extremely high IOP, particularly in acute angle closure emergencies or sometimes before eye surgery. They work systemically by increasing the concentration of dissolved substances in the blood, which then draws fluid out of the eye by osmosis.
Hmm.
The material lists numerous potential side effects for these, including lethargy, headaches, seizures, paresthesias, tingling sensations, changes in mental status, GI issues, increased urination, thirst, and significant fluid and electrolyte imbalances. The source notes they are often considered a last resort due to these side effects and may not be as effective as other options in certain situations. The material then covers cycloplegics and mydriatics medications used mainly in diagnostic procedures or surgery to manipulate the pupil and the eye's focusing muscle. Right. These are primarily anticholinergic medications that block the action of acetylcholine on specific muscles within the eye. Cycloplegics paralyze the ciliary muscle, which controls focusing, causing cycloplegia or loss of accommodation, basically, temporary difficulty focusing on near objects. Mydriatics dilate the pupil, mydriasis. Examples include atropine sulfate, cyclopentolate, phenylephrine hydrochloride, which dilates the pupil but doesn't significantly affect focusing, and tropicamide. They're used to allow the doctor a better view of the back of the eye during an exam or to keep the pupil widely dilated during certain surgeries, like cataract surgery.
The material calls atropine sulfate the most potent cycloplegic and notes it has the potential for severe systemic side effects, though less common with eye drops. Seizures, arrhythmias, hypotension, and respiratory depression. It's contraindicated in glaucoma, as dilation can worsen angle closure, and tachycardia, as it can increase heart rate.
Yes, while rare with standard topical use, significant systemic absorption can occur, especially in children or with overuse. Other potential systemic side effects include dry mouth, headache, constipation, increased IOP, psychosis, tachycardia, and muscle rigidity. The expected ocular side effects are dry eyes, photophobia, significant sensitivity to light due to the dilated pupil, and blurred vision due to both the dilation and the inability to focus up close.
Makes sense. The material wraps up the eye section with clear, practical instructions for administering eye drops and ointment, pulling down the lower lid to create a pouch, applying the drop or ointment into the middle third of that conjunctival sac, and applying gentle pressure over the lacrimal sac after drops. For ointment, just a small quarter-inch strip into the sac.
These steps are really important for getting the medication into the eye effectively, and with that lacrimal sac pressure technique, minimizing the amount that drains into the nose and gets absorbed systemically. And a really key detail if a patient needs multiple different eye drops. The material instructs waiting at least 5 minutes between putting in different types of drops.
Why wait?
To prevent the second drop from immediately washing out the first drop before it's had time to be absorbed by the eye tissues, gives each medication a chance to work.
Okay, good practical tip. Moving on to ear disorders. The material discusses anti-infectives for acute otitis media, which is a middle ear infection common in kids,
Very common.
and acute otitis externa, known as swimmer's ear, which is an infection of the outer ear canal.
Right. For acute otitis media, which occurs behind the eardrum and is often bacterial, oral antibiotics are the standard treatment. Examples listed are amoxicillin, azithromycin, or clarithromycin. For acute otitis externa, since the infection is localized to the ear canal itself, topical treatments, antibiotic ear drops are frequently preferred.
Okay.
The source lists combination drops containing antibiotics and steroids, like neomycin, polymyxin B, and hydrocortisone. The steroid helps with inflammation and itching, as well as other antibiotic options like chloramphenicol and fluoroquinolone ear drops like ciprofloxacin or afloxacin.
Side effects for ear anti-infectives, mostly local.
Mostly local, yes. Side effects in the ear canal can include burning, stinging, irritation, and the possibility of superinfection, meaning a new infection, often fungal, developing during the course of antibiotic treatment because the normal bacteria are altered.
Okay.
A more significant, though less common with topical ear drops compared to systemic forms, is the potential for ototoxicity, or damage to the inner ear that can affect hearing or balance. This is primarily a concern with aminoglycoside antibiotics like neomycin or gentamicin if the eardrum is perforated and the drops get into the middle ear. Chloramphenicol eardrops also carry a rare but serious warning about potential bone marrow suppression, even with topical use.
The material provides simple, effective administration tips for eardrops, too. Positioning the patient so the affected ear is upward allows gravity to help the drops flow down into the ear canal. Gently pulling the auricle, the outer part of the ear, downward and back for adult.
That helps straighten the canal.
Helps straighten the canal. Interestingly, the typical instruction for children is often up and back, but this source specifically says down and back for adults. And being careful not to touch the dropper tip to the ear helps avoid contaminating the rest of the medication in the bottle.
Good basic hygiene. Yeah. Finally, serum analytics are mentioned for the ear. What are those?
These are topical agents specifically used to soften or break up excess earwax or cerumen to make it easier to remove.
Ah, earwax softeners.
Exactly. The material mentions water-based options that work by hydrating and disintegrating dried wax, and oil-based options like mineral oil or olive oil that lubricate and soften the wax, making it easier to flush out or remove manually. All right, our final section takes us skin deep, covering common dermatologic disorders. It starts with the very widespread condition, acne vulgaris.
Acne is incredibly common, particularly during adolescence, but can persist into adulthood. It's characterized by clogged pores, blackheads, whiteheads, pimples, papules, pustules, and sometimes more severe, deeper lesions like cysts and nodules. The material lists both non-pharmacologic approaches and prescription treatments, suggesting a stepped approach depending on how severe it is.
Non-pharmacologic measures listed sound like pretty standard good basic skincare advice. Regular cleansing, shampooing hair frequently, especially if it's oily and touches the face, using water-based or non-comedogenic cosmetics, maybe considering diet and stress reduction as potential contributing factors, and definitely avoiding harsh or abrasive cleaners or excessive scrubbing that can actually worsen inflammation.
Yes, those lifestyle and basic hygiene factors are important foundations for managing acne. For mild to moderate acne, topical anti-acne drugs are the usual first-line treatments.
Benzoyl peroxide is listed as a common first choice. The material describes it as a keratolytic agent. What does that mean?
Keratolytic means it helps the outer layer of skin shed more effectively, which helps unclog pores. Benzoyl peroxide also has a direct antibacterial action against P. acnes, the bacteria that contributes to acne inflammation. It works by releasing free radical oxygen that helps kill the bacteria.
Okay.
The source notes that you typically start seeing significant improvement after about 4 to 6 weeks of consistent use. It also cautions about maybe rotating application times if you're using other topical treatments to minimize potential irritation, redness, and peeling, which are common side effects.
Salicylic acid is another topical keratolytic option mentioned, which also promotes desquamation, that shedding of the horny outer layer of the skin. But the material includes a specific warning about it, similar to aspirin.
Yes. While it's effective for exfoliation and helping unclog pores, it's important to be aware of the potential for salicylic toxicity, particularly if applied over large body surface areas or to broken skin, though it's less common than with oral salicylates. Crucially, the source advises avoiding salicylic acid in children with viral infections due to a theoretical increased risk of Reyes syndrome. While primarily associated with aspirin, other salicylates carry a similar warning in that context.
Okay. Topical retinoids are also listed. These are derivatives of vitamin A, like tretinoin, often known as retin-A, adapalene, and tazarotene. How do they work?
Topical retinoids work by normalizing how skin cells mature and shed, keratinization, which prevents the formation of microcomedones, the earliest acne lesions. They also have significant anti-inflammatory effects and help break down existing comedones, blackheads and whiteheads. A critical instruction with their use is to avoid sun exposure, or at least use very good sun protection, as they make the skin much more sensitive to UV radiation and prone to sunburn. Tazarotene is specifically highlighted as being contraindicated in pregnancy due to the risk of birth defects, similar to oral retinoids.
The material mentions that often patients might be prescribed a combination of topical agents or stronger concentrations, listing Epiduo Forte, which combines benzoyl peroxide and adapalene, a retinoid, as an example. That makes sense, using different mechanisms of action together to tackle the acne.
Exactly. Combination therapy is very common for moderate acne. Oral antibiotics are often used for more widespread or inflammatory acne breakouts that don't respond sufficiently to topical treatments alone. Examples given include doxycycline, minocycline, and tetracycline.
And tetracycline has a specific contraindication and interaction worth noting, right? Something about teeth and dairy.
Yes, tetracycline is contraindicated in pregnancy and in children under 8 years old because it can bind to calcium in developing teeth and bones, causing permanent yellow-brown discoloration of teeth and potentially affecting bone growth. It also interacts with calcium in food and supplements, so the material notes it can cause dental discoloration in adults too, though less common, and reduced absorption if taken with dairy products, calcium supplements, or antacids containing calcium, magnesium, or aluminum. They need to be taken separately.
Got it. Topical antibiotics are also mentioned, working by concentrating in the hair follicle where the acne bacteria reside, providing both anti-inflammatory and antibacterial effects.
Right. Then the material also covers isotretinoin, which is an oral vitamin A derivative reserved for severe nodulocystic acne that hasn't responded to other treatments, including oral antibiotics. It's very effective medication, but comes with significant considerations. The typical course is 4 to 6 months.
It sounds very effective, but you said significant considerations. It has a list of side effects and a major contraindication.
It does. It is highly effective, often leading to long-term remission, but the side effect profile is extensive. Common side effects include cheilitis, severe inflammation and dryness of the lips, almost universal, dizziness, headache, conjunctivitis, eye inflammation, pruritus, itching, widespread skin dryness and irritation, muscle and joint pain, myalgia, arthralgia, nosebleeds, epistaxis due to dryness, hair thinning, and significant photosensitivity. More seriously, changes in mood, including depression and suicidal thoughts, have been reported and are listed as potential adverse effects, requiring careful monitoring during treatment. Elevated triglycerides and liver enzymes are also monitored via blood tests.
And that major contraindication.
Pregnancy. Isotretinoin is a potent teratogen, meaning it causes severe life-threatening birth defects. It is absolutely contraindicated in pregnant women.
Absolutely contraindicated.
Yes. The source explicitly mentions the IPL-DIG program, which is a mandatory risk management program in the United States requiring all patients, both male and female, prescribers, and dispensing pharmacies to register. Patients capable of becoming pregnant must use 2 forms of effective contraception and undergo regular pregnancy testing before, during, and after treatment to ensure pregnancy is prevented.
Wow. That highlights just how serious the risk of birth defects is with that medication. It's not taken lightly.
Not at all. Okay, next. Psoriasis is discussed a chronic inflammatory skin condition characterized by well-defined red plaques covered with silvery scales, often appearing on areas like the elbows, knees, scalp, and lower back.
The material asks, is this contagious?
Yeah.
With the clear implication that the answer is no.
Correct. Psoriasis is an autoimmune condition. The immune system mistakenly attacks healthy skin cells, causing them to grow and divide much too rapidly, leading to the buildup of those thick, scaly patches. It is not caused by an infection and cannot be spread from person to person. Topical treatments are often the first step for mild to moderate psoriasis and include corticosteroids, often the mainstay, vitamin D analogs like calcipotriene, tazarotene, a topical retinoid, salicylic acid to help remove the thick scales so other medications can penetrate, and sometimes older treatments like coal tar preparations. A typical course of topical treatment might last around 4 weeks to see improvement.
The potential side effects of topical steroids for the skin are listed again here, and they go beyond simple irritation, especially with long-term or potent use.
Yes, prolonged or widespread use, particularly of higher potency topical steroids, can lead to local side effects like skin atrophy, thinning, making the skin fragile, telangiectasia, visible small blood vessels, sometimes called spider veins, stria distensae, stretch marks, acne-like eruptions, folliculitis, inflammation of hair follicles, and easy bruising, purpura. There's also a risk of fungal infections or the condition actually worsening if used improperly or stopped abruptly, rebound effect. And if applied over large areas of the body or under bandages, occlusive dressings, which increase absorption, enough medication can potentially get into the bloodstream to cause systemic side effects.
Even from the cream.
Yes. These can include growth retardation, a concern in children with extensive use, Cushing syndrome due to excess steroid in the body, and even cataracts and glaucoma, similar to the concerns we saw with ophthalmic steroids if absorbed systemically.
So even a cream needs careful use. Systemic drug treatments for psoriasis are also listed, used for more severe or widespread disease when topical treatments aren't enough. These include methotrexate, cyclosporine, acitretin, another oral retinoid, and biologic response modifiers, BMRs.
Right. These medications have more significant effects on the immune system or cell growth and require much closer monitoring by a healthcare provider. The material notes that for all systemic treatments for psoriasis, assessing for underlying chronic infections, such as latent tuberculosis or hepatitis B, before starting treatment is crucial.
Why is that?
Because these medications suppress the immune system to control the psoriasis, they can inadvertently allow previously controlled infections to become active and serious. Methotrexate is an antimetabolite that slows the rapid skin cell growth, but has serious potential side effects, including oral ulcers, stomatitis, significant GI distress, fatigue, and it is teratogenic, causes birth defects. More seriously, it can suppress bone marrow function, leading to low blood counts, cause liver damage, hepatotoxicity, and scarring of the lungs, pulmonary fibrosis. Regular blood monitoring is essential. Cyclosporine is another powerful immunosuppressant used to calm the overactive immune system in severe psoriasis. Side effects listed include hypertrichosis, excessive hair growth, fatigue, hypertension, high blood pressure, nephrotoxicity, kidney damage requiring monitoring, headache, muscle and joint pain, paresthesia, tingling numbness, and weakness, asthenia.
And BMRs, or biologics, are a newer class of systemic treatments. These are typically proteins, often antibodies, that target very specific molecules or cells in the immune system known to drive psoriasis. The material notes they tend to have a better safety profile regarding broad systemic side effects compared to older systemics like methotrexate or cyclosporine, but they are very expensive and are typically used when other options have failed or are contraindicated. They are absolutely contraindicated in patients with active infections like TB or Hep B because they significantly suppress parts of the immune system needed to keep those infections in check. They can also increase the risk of other infections. Then the material covers eczema, specifically contact dermatitis and drug-induced dermatitis. The general signs and symptoms for these inflammatory skin reactions are listed as rash, hives, urticaria, papules, small raised bumps, vesicles, small blisters, intense itching, burning, stinging, larger blisters, boule, swelling, oozing, and scaling. Pretty miserable sounding.
It can be very uncomfortable. The material also mentions more severe, potentially life-threatening skin reactions that can be triggered by medications, such as erythema multiforme, Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TEM.
SJS and TEN sound particularly serious.
They are. They are medical emergencies where the top layer of skin, epidermis, detaches from the layers underneath over large areas of the body, similar to a severe burn. They require hospitalization, often in a burn unit, for critical care.
A crucial caution highlighted here is the importance of watching for signs of drug hypersensitivity reactions presenting as skin symptoms and carefully reviewing the patient's recent medication history, especially new medications. The material lists specific classes of drugs known to be common culprits for these severe skin reactions, including certain antibiotics like sulfa drugs, anticonvulsants, isoniazid, a TB drug, and procainamide, an antiarrhythmic.
Yes, recognizing a potential drug reaction early is key. Contact dermatitis, a common form of eczema, is discussed in more detail. It's an inflammatory reaction caused by direct contact with either an irritant, like a strong soap, detergent, solvent, or chemical, or an allergen, like poison ivy, oak, sumac, latex, certain metals like nickel in jewelry, fragrances, or preservatives.
Okay.
It typically appears as a localized reaction in the area that touched the substance, presenting with symptoms like dry, cracked skin, bleeding, a rash, intense itching, maybe burning or stinging, blistering, swelling, oozing, and scaling.
Non-pharmacologic measures for contact dermatitis sound straightforward. Identify and strictly avoid the irritant or allergen if possible. Use protective clothing or gloves when exposure is unavoidable. Wash the area immediately and thoroughly after potential exposure, and use soothing measures like cool wet compresses or colloidal oatmeal baths to relieve itching and inflammation.
Those are the cornerstones. Pharmacologic measures include applying cool wet dressings soaked in solutions like Burdo's solution, aluminum acetate, which acts as an astringent to help soothe and dry weeping or blistering lesions. Using barrier creams like zinc oxide lotions or soothing lotions like calamine for symptomatic relief of itching and irritation. Taking oral antihistamines can help manage the itching, especially at night, and applying topical corticosteroids is often necessary to reduce the underlying inflammation.
And there's another reminder here about avoiding long-term or widespread use of potent topical steroids to prevent skin thinning and potential systemic effects, echoing the cautions we saw with psoriasis treatment. Use the lowest effective strength for the shortest possible time.
Exactly. Next, the material discusses burns.
The types listed are thermal burns, most common caused by heat like fire, steam, hot liquids, electrical burns from electricity, which can cause deep tissue damage, and chemical burns from corrosive substances. The severity and treatment depend heavily on the depth, first, second, or third degree, and the extent, percentage of body surface area of the burn.
Right. For mild burns, like a first-degree burn, like a sunburn, or a small second-degree burn, blisters, treatment involves applying cool, wet compresses, but definitely avoid ice, which can worsen tissue damage, gently cleansing the area with mild soap and water, keeping it clean to prevent infection, importantly not opening blisters if they are intact, as the blister roof provides a sterile barrier and reduces pain, and perhaps using over-the-counter antibiotic ointments like bacitracin or neomycin to prevent local infection.
Okay, but for more severe second and third degree burns, the risks are much higher, right?
Significantly higher. The main immediate risks are dehydration due to massive fluid loss through the damaged skin barrier, sepsis, widespread overwhelming infection entering through the burn wound, and localized infection in the burn wound itself. These require aggressive medical management, often in a specialized burn center. This includes large volumes of intravenous fluids to replace losses and maintain circulation and kidney function, meticulous wound care, nutritional support, and topical broad-spectrum anti-infectives applied directly to the burn wounds to control bacterial and fungal colonization.
Silver sulfadazine cream, Silfadine, is highlighted as a common example of a topical broad-spectrum anti-infective used for moderate to severe burns. Its action is being active against a wide range of pathogens, gram-positive bacteria, gram-negative bacteria, and even some fungi like Candida. It's specifically used to prevent and treat infections in second and third degree burns and is typically applied thickly, at least twice daily, after the burn wounds are cleansed.
Side effects can include photosensitivity, temporary skin discoloration, often a harmless grayish color, local reactions like burning, rash, or redness, and in rare cases with extensive absorption over large burn areas, potentially skin necrosis or leukopenia, a decrease in white blood cell count due to the sulfa component. Because it contains sulfur, it's contraindicated in patients with sulfa allergies, in near-term pregnancy, and in infants less than 2 months old due to the risk of kernicterus, a type of brain damage.
The material provides a list of key nursing interventions for burn care that really gives you a picture of the intensive management involved, administering pain release before wound treatment, because cleaning and dressing changes are notoriously painful. Meticulously cleansing burn tissue using aseptic technique, a clean method to reduce pathogen transfer. Applying topical antibacterial drugs and dressings using sterile technique, completely free of pathogens, to prevent introducing infection. Maintaining fluid balance and monitoring renal function, urine output is a key indicator. Monitoring for systemic side effects of topical drugs, like watching the white blood cell count with silver sulfadazine. And monitoring vital signs constantly for signs of infection, like fever or increased heart rate, or hypovolemic shock, low blood pressure, rapid heart rate from severe fluid loss. That really shows the comprehensive, multifaceted care needed for severe burns.
It's incredibly complex care. Rosacea is briefly covered next, a common chronic inflammatory skin disorder primarily affecting the central face. Cheeks, nose, forehead, chin.
Signs and symptoms include facial rash, frequent flushing or blushing, persistent redness, swelling, sometimes thickened skin, especially in the nose, called rhinophyma, visible small blood vessels, telangiectasias, and acne-like breakouts, papules and pustules. Unlike acne vulgaris, it doesn't typically involve blackheads or whiteheads, comedones.
Treatment involves identifying and avoiding individual triggers, which can vary greatly but often include sun exposure, a major one, hot or cold temperatures, wind, spicy foods, alcohol, hot beverages, and emotional stress. Limiting UV exposure is crucial, as is using gentle, non-irritating skin cleansers and moisturizers. For the inflammatory breakouts, topical treatments like azelaic acid, topical antibacterials such as metronidazole gel or clindamycin, or sometimes topical retinoids may be used. Daily use of a broad-spectrum sunscreen is also highly recommended for everyone with rosacea.
Impetigo is mentioned next as a common bacterial skin infection.
Yes, it's usually caused by bacteria like Streptococcus pyogenes or Staphylococcus aureus. It's particularly common in young children, often between the ages of 2 and 5 years old, and it's quite contagious. It typically starts as small red sores, often around the nose and mouth, which quickly rupture, ooze of fluid, and then form a characteristic yellowish-brown, honey-colored crust.
Because it's a bacterial infection, treatment involves antibiotics.
Correct. Treatment includes topical antibiotic ointments like mupirocin, Bactroban, and retepamulin, Ultibex, for localized infections. Sometimes soaking the lesions gently with warm water is recommended to help remove the crusts before applying the ointment, allowing the medication to penetrate the infected skin better. Oral antibiotics may be needed if the infection is more widespread, more severe, or not responding effectively to topical treatment alone. Good hygiene is also important to prevent spreading it.
Finally, the material briefly discusses hair loss or balding, also known as alopecia, as a dermatologic concern.
Right. The causes, or etiology, can be quite varied. The most common type is androgenetic alopecia, or male-female pattern baldness, which is related to genetics and hormones. Other causes include aging, certain drug-induced causes like chemotherapy, some blood pressure medications, antidepressants, hormonal changes like those after pregnancy, or thyroid issues like myxedema, systemic conditions associated with cancer therapies, or specific nutritional deficiencies like severe iron, folate, or B12 deficiency.
Pharmacologic treatments mentioned are aimed at promoting hair regrowth in certain types of hair loss. Minoxidil, known commercially as Rogaine, is a topical treatment available over the counter for both men and women.
While originally developed as an oral blood pressure medication, it was serendipitously found to cause hair growth. The exact mechanism for hair growth isn't fully understood, but is thought to involve improved blood flow to hair follicles and prolonging the growth phase of the hair cycle. Hair regrowth, if it occurs, is usually seen after several months of consistent twice-daily application, and it stops if you stop using the product. Side effects are generally mild and local, like scalp irritation, though slight systemic effects like mild hypertension or headaches are possible if absorbed.
And finasteride, known as Propecia for hair loss or Proscar for another use, is an oral medication typically just for men with male pattern baldness.
Right. Finasteride is a 5-alpha reductase inhibitor. This enzyme normally converts testosterone to dihydrotestosterone, DHT. DHT is a hormone that contributes to hair follicle shrinkage and hair loss in individuals genetically susceptible to male pattern baldness. By lowering DHT levels specifically in the scalp, finasteride can slow hair loss and promote some regrowth in many men. Hair regrowth is typically seen after about 3 months or more of daily use, and again, the benefit is lost if the medication is stopped.
And this medication has a significant contraindication, similar to isotretinoin in a way.
Yes, it is absolutely contraindicated in pregnant women because it can cause abnormalities in the development of the external genitalia of a male fetus. For this reason, women who are pregnant or who may become pregnant should not even handle crushed or broken finasteride tablets due to the risk of absorption through the skin. The material also notes that finasteride is used at a higher dose, marketed as Proscar, for treating BPH, benign prostatic hyperplasia, which is non-cancerous enlargement of the prostate gland that can cause difficulty with urination or urinary retention in older men. This highlights another application for the same drug based on its hormonal effects in different tissues. Hashtag outro.
Wow, that was truly a deep dive. We really covered so much ground there, from understanding why that runny nose stops with one pill but maybe not another, all the way to managing complex chronic conditions like glaucoma and severe acne. Pretty fascinating how many different medications are out there, each with really specific ways they work and specific things you absolutely need to know about using them safely.
It really is. Looking back at all this material we just went through, what stands out most to you? Was it maybe the fundamental difference in how first and second gen antihistamines affect you day to day, or the absolute necessity of correct inhaler technique and timing? Or maybe the unexpected systemic risks associated with certain eye drops, or perhaps even that surprising second life for a drug like Mucomyst as an antidote?
You know, for me, I think the biggest takeaway is really understanding the why behind the cautions and the contraindications. Knowing why you shouldn't use decongestants if you have high blood pressure, or why beta blocker eye drops need caution if you have certain heart or lung conditions, it makes you really appreciate how interconnected all our body systems are.
Absolutely.
And it underscores just how crucial it is to have a full and honest conversation about your complete health history with your doctor or pharmacist before starting anything.
Absolutely. And all those specific administration details we talked about, the right way to use an inhaler or eye drops, the need to wait between different eye drops, the warning about nasal spray overuse, they really highlight that how you use a medication is often just as important as knowing what the medication is supposed to do. These aren't just minor suggestions, they're critical for ensuring the drug works properly and avoiding potential harm.
So here's a final thought to maybe leave you with. We explored medications for conditions that affect pretty much everyone at some point, from a simple cold or allergies to managing a chronic skin issue like acne or eczema. Given the sheer number of available treatments, the really nuanced ways they work, and all the layers of specific instructions and potential interactions we discussed, what does this level of pharmacological detail reveal about the complexity of even seemingly common health problems? And perhaps the value of taking the time to truly understand the tools we have to manage them, not just taking them at face value.
That's a great point. It's something to think about next time you're looking at a bottle or tube of medication, over the counter or prescription. Your informed use is really a key part of your health journey.
Thanks for joining us for this deep dive. We hope it's provided you with some truly valuable insights into these common medications.